This, being room 3, is the room for the wonderful colleagues that we in the Restricted Practices Unit are really privileged to actually call colleagues, and have become to know over the years that we've been a unit, that we've been pursuing the reduction and elimination of the use of restricted practices, in particular in the disabilities sector. So without further ado, I am going to hand over to this wonderful group of people, but just so you know you're in the right room, these are the South Australian Intellectual Disability Health Service, or SAIDHS, and they're a statewide service, as many of you would know. They're a specialist health service for adults with intellectual disability and complex care needs. And one of the wonderful things that I particularly personally enjoy about working with these colleagues is that they have both the medical, as you would expect, expertise, which is very, very important, but they also practice from an allied health perspective as well.
Myself, I'm just going to perhaps send you the link again from here, if that's okay. Hold on the line to make sure you get it. What's your email address, please?
Be quiet. I will have a roving microphone throughout to be able to take any questions that you may have. I'm aware that we also have people online, so please type in your questions. We will be capturing those, and if there are any themes to those, we'll draw those together and then present to the team as well. The preference, just in terms of timekeeping, is that if you've got any burning questions, by all means, pop up your hand, but there will be opportunity for questions at the end of the session so we can get through all the fabulous content. But I now welcome Stephanie to come and take us through. Thank you.
Wow, what a fabulous introduction. Thank you. So we're here from SAIDHS. Oh, great to start on the tech. Let's see if I click it again. Does it do anything? Oh, I was too slow. We would just like to acknowledge the Kaurna people as the traditional custodians of the land where we're gathering today, and honour Kaurna elders past, present and emerging, and recognise Aboriginal Cultural Authority and their ongoing spiritual connection to country. I've got several people from our team here today. We've got Paul Jones, our nurse consultant, June Buxton, our senior pharmacist, and as introduced before, the amazing Dr. Bahman Zarrabi, who we are very fortunate and blessed to have in our team. And I do want to also acknowledge that some of the content we're speaking about today has been prepared by other members of our team from other professional backgrounds that aren't here, and we appreciate their input into these slides. So just a bit of an outline, we're going to give you a bit of a snapshot of how we use our multi-D team and how other multi-D teams can work in understanding the person and what's going on for them, the importance of deprescribing, some strategies for successful deprescribing. We're going to use some case studies to try and give it a bit of a lived perspective, and we will have some time for some Q&A at the end. Before I go any further, I do want to also acknowledge people with lived experience of intellectual disability, their families and carers, and recognise their valuable contribution to our Australian society as well as across the globe. And just a bit of a pause here, some of what we're going to be talking about may be things that we have different perspectives on. So we just like to prompt people to just have an awareness that we all bring our own assumptions and beliefs to things when we're looking at situations, and just kind of flag that we need to note that and be wary of, is this our own assumption or belief that we're bringing into this, or are we able to be looking at it from the perspective of the person that we're working with? So Dan was a patient referred to SAIDHS. He was on a palliative pathway for recurrent bowel obstructions. His current medical treatment doesn't seem to be working. He's continuing to have significant behavioural issues. Both his mum and carers are feeling really out of their depth with the current management. He's an NDIS participant, and he also has support from the local palliative care nurses. He's non-verbal and has presented to the Royal Adelaide Hospital a number of times. His mum is finding his care increasingly stressful, and they would appreciate some specialist assistance. So Dan is a 21-year-old male. He was born at 27 weeks premature. He's got some complex genetic conditions as well as some other medical conditions going on. He lives with his parents, who are his main carers, in a regional area, and his behaviours present as agitated, aggressive outbursts. These have become more frequent, and he's frequently hitting his head and biting his hands. Previously, he used to enjoy swinging. He would be able to make some happy vocalisations, but he's now appearing sad all the time and not enjoying life. His current prescribed medications are having a very limited effect, and his mum doesn't want any life-prolonging measures that may increase his suffering. The other thing to note is that he weighs 35 kilos, so he's incredibly little. This is a deprescribing example, not so much in the context of antipsychotics, but polypharmacy more broadly. And we thought it was really important to use this as another example that this is another element of deprescribing that we all need to have on our radar and be considering. So for us to have success with deprescribing, we need to understand the person and what's going on. And often the beginning of that phase feels like being presented with a jumble of puzzle pieces. And we may not even have all the puzzle pieces that we need, but somehow we need to find a way of working our way through that. And one of those ways that we can do that is relying on our multi-D colleagues to try and contribute their piece of the jigsaw puzzle so that we can understand the broader picture of what's going on for the person. So everyone's got their own specialty area, and I just want to flag that we're going to talk to several different specialty areas today. I'm not going to cover all of the elements of a multi-D team, so if there's a discipline that we've left out, it's not because we don't think they're important, we're just focusing on a few key areas for today. I'm an OT by background, so I can certainly speak to where OTs come into this picture. OTs are always interested in making people as functional and independent as possible, but we're also interested in how different things interact to impact that for the person. And majority of the time, our system expects the person to fit in, and that just doesn't work for a lot of our disability clients and cohort. And we really need to be able to think more broadly about where are some of the other variables that we may be able to change to increase their success and their function overall. People's sensory function can be part of that as well, obviously, but again, that's one piece of what OTs can contribute. Similarly, functional capacity assessments are one thing that OTs can do. They're not our only thing, but in this NDIS world, that's a big part of what OTs are now doing. So with specific link to Dan and his case study that we're talking about, he's displaying a lot of sensory seeking behaviour that may or may not be being met at the moment. He's also got very limited engagement in activity outside of his home. At an equipment level, he's still using paediatric equipment at the age of 21, and a lot of his equipment is stuff that mum's just kind of sourced ad hoc, combination of reasons with that, some of which is her NDIS funding for him. Pressure care is a significant issue. At 35 kilos, he's got a lot of bony prominences, and that needs to be effectively supported for him. He does have NDIS funding available, but it's not currently being utilised to the fullest ability. So where can we do some of that tweaking to make things better for Dan? Another piece of the jigsaw puzzle is social work and understanding some of the psychosocial factors that are existing for the person. Their NDIS supports, they may or may not have a sufficient level of funding for their behaviour support needs to be managed in a least restrictive way. Carer burnout and the impact that that has on carers' ability to provide for their child or the person they're supporting. Additional financial stresses. We certainly see a lot through our service where people through inadequate funding have had parents that have had to give up work to be able to provide care for their patients, our patients, their child, and that has a significant impact on their overall situation. Other considerations around legal guardians, the perspectives of the primary carer. Often it's not always the legal guardian that may be presenting with the person to their appointment or their interaction with your service either. So it's really important to kind of find out who the right people are to be talking to. And then in our team anyway, our clinical care coordinator is an invaluable person as far as case coordination, which is often a missing puzzle in this jigsaw. So again, linking it back to Dan's case study, Cheryl and her husband have been supporting Dan with his complex disability for the last 20 years in their own home. They've had very limited support because they're geographically isolated. Carer burnout is a significant factor for them. They've had very limited education and support from the clinicians and healthcare people they have had encounters with. And mum is making comments to us like they saved a baby at 27 weeks that perhaps shouldn't have been saved. So mum's dealing with a lot of her own emotions around that. one too far, sorry. Another aspect that was considered from the social work side of things, we ended up working with the adult safeguarding unit. Until we had more information, there were some concerns around his low weight and the fact that his weight was being kept at that level. We were able to meet with the adult safeguarding unit and collaborate with them and develop a plan around going out to the house and actually laying eyes on the situation and understanding things from a first-hand perspective. And we were then also able to make a referral to a dietitian for some further input around his weight management. I'm going to hand over to Paul, who's going to speak to the next pieces of the jigsaw puzzle.
Thanks, Steph. So I'm going to do on behalf of our speechy and nursing as part of the puzzle. So everybody uses behaviour to communicate, whether it's positive or negative behaviour. Behaviour paints a picture of a person's situation, and I think that's really important to remember, especially in our cohort of people who can't communicate like we can, even though I'm communicating really nervously right now. It's still a bit of a behaviour. But most people are actually quite skilled in hypothesizing what's happening to people around us. When it comes to considering what behaviour is communicating in a disabled context, things often break down because, again, back to what Steph was saying, we're always ready to make assumptions. When we're talking about the history of prescribing and deprescribing, the history was to prescribe more and more because we just reacted to reactions and situations. So understanding the behaviour. So are these concerns long-standing or new? Again, sometimes people historically have done a lot of self-harm, and we always judge people from past experiences. We're never actually ready to look at a new perspective, a new view. And I think it's really important to have, an open mind, because things change, research change, historical changes, medication changes. So we always need to put everything into perspective. And sometimes, in old adages, never reinvent the wheel. Sometimes we have to reinvent the wheel, and it's really important to start from scratch. Are there patterns in the behaviours? Any changes in environmental factors? As we know, from institutionalisation to NDIS and accommodation, SIL, SDA, people go through changes. People don't have enough funding in their plan to have the purpose-built facilities. Someone does, or someone was in an institution, a lot of money spent to relocate, and they get a lot of money and they get a really good environment to go in, but they're not ready for that environment. We never think about things like that. A lot of the people that were in institutions were actually settled and quite happy. Some people weren't, but we never put everybody, give them individual views on. We just go, everybody needs to get out. So environmental factors can be really, really difficult. Weight gain, again, environmental factors can attribute to that. And is there an unmet needs? Poor communication or poor understanding of communications could sometimes mean that we misunderstand what's happening and we don't meet that person's needs. So physical health and nursing, some of the things that we kind of diagnose and understand, and the issues that can arise that we really, as a multi-D team, we have the opportunity as a nursing team to support the medical team with abuse and trauma, finding out history, constipation, doing bowel charts, identifying issues, patterns, dental pain and gum disease. I think if somebody would make a research on dental hygiene in people with intellectual disability, would be very, very, very poor, because it's too hard. So we don't go there. So people, gum pain, gum disease, very, very painful, if you've been through it yourself. Hunger and poor nutrition. Again, poor diets, poor calorific intake, poor vitamins, everything like that can contribute to a behaviour. We just need to find out what it is. Psychiatric disorders, we do that in a bit of a nursing intake. As a multi-D team, we are the first point of contact as nursing. We go in and do a nursing intake to collate all the information ready for either whoever sees them next, whether it's allied health or a doctor. We collate as much information as we can so everybody can have an informed information. Thyroid disease, something I've learned now from the medical team at SAIDHS, is the importance of bloods. How often do our people have bloods taken? Very, very rarely. And it's only through our great doctors that I've learned the importance of bloods. and how often blood should be taken and what it identifies in people. It's massive. So ABC charts is something that we'll always go into a house and ask people to do. I think they really are important to identify changes, identify same. If it's same, then don't fix it. But if there are changes happening, it's a great way to identify. And I'm not going to teach you all to suck eggs about what ABC means, but I think it's really important. If you're all managers or if you're team leaders or house leaders, please make sure your staff complete these forms, because they're really important for us to kind of collate that information and provide that feedback. It's so often that we ask for things to be done and they're not done. But if just that little word, please complete them, 7 days, that's all you need to do. I think it just paints a great picture for us. That's just a bit of a copy of an ABC chart. And then the next one is bowel. As a nurse, we love bowels. I don't know how many nurses are here, probably not many, but we're quite proficient in bowels. But it's been identified that bowel discomforts can be a trigger for behaviours for our cohort. The inability to express discomfort and pain can lead to frustration and aggression towards themselves, parents and carers. Monitoring bowel movement is a key component to identify when and why behaviour is occurring. Ensuring staff complete bowel charts will help provide the MDT the evidence to support the right course of action treatment for the patient. Bowel, please have people fill them in. Again, it shows great action or not so great action. And long-term effects of using Movicol, Senna, all that stuff can be looked into it. And I don't know if I'm right, I didn't think I was reading this one. It's okay, get surprised, get in. I can't say these medications anyway. That first one, yeah. Those two top ones might contribute to constipation. I don't use words like this. But again, it's all about bowels, and you see Dan was on those medications that contribute to poor bowel health. And then, so that's his medication list. Again, you can look at it. I think it's easier for you to do so. A lot. And who's next to sort that out? It's our doctors. It's the doctors in here. It's everybody. But without being informed on what's happening behind the scenes from a nursing perspective, they're not informed well enough to make those decisions, and it's very hard. So it's really important to collate all those information from a nursing perspective so that people are informed. So multiple admissions in hospital for bowel obstruction, complications including being managed with an NGT tube. Developed COVID-19. This added to Dan's ongoing, like the previous meeting about long COVID, stuff like that. We got identified quite quickly. In an admission October 22, Mum had approached clinicians for options regarding medically assisted death for Dan, referred to palliative care, reviewed at telehealth. That's quite an extreme pathway to go on. Behaviours of concern was screaming and punching himself in the head, noted when interrupted from his favourite activities, watching TV, to shower or change incontinence pads. Dan no longer seemed happy. That could be anybody in any house, can't it? When we get diverted from our favourite tasks. Concerns regarding restrictive practices and chemical restraints, high doses of opioids, as you can see in the medical list I had, and then significant changes over time. So high risk of death due to respiratory depression on a background of low body weight. The BMI was estimated between 12 and 13. Although this might not have been acceptable had it been receiving end-of-life care, there's no clear indication that that was the case. So significant changes in behaviour last week stopped the meds due to withdrawal rather than inability to absorb medications orally in adequate doses. And I think I need to hand over to June. Thank you.
So I'll pick it up from there. So when there was a first pharmacy presentation in June, how do I go back? A few slides. How do I? Red? Okay. go back quickly. So this is the first pharmacy review, and what we found is this list of medications. So just quickly for perspective, benztropine up there really is to help with drooling. Dan has excessive drooling. Pyrazine is an antipsychotic, so it helps. What we found out is he's been on it for the last 5 years for behaviours of concern, and then. What I'd like to highlight quickly also is with morphine, he's on 2 opioids, so that's a pain patch and he's on morphine. So with morphine, there was no frequency prescribed. So mum was giving 1 to 2 meals up to 4 times a day for when Dan's in distress. So basically she's interpreting the distress as pain. So we're just giving it as we go. With clonazepam as well, clonazepam is a benzodiazepine, so it's long-acting, meaning it accumulates in the body. So big doses where mum's giving 5 drops morning and 5 drops in midday and 7 drops at night, which is a lot more than what I would see in the palliative care setting. So the more you give this, the drowsier they get, and perhaps you query whether that's, mum, he's sleeping really well at nighttime, whether that would have contributed to it, and he's only 35 kilos, remember? Then what we've also found out in the review is immediately the day before we have seen him the first time with pharmacy, he is on the bottom list of medicines, which is the subcutaneous medication. He was on palliative care, but it was stopped abruptly and not slowly reduced as that he should be. Looking at when we do a pharmacy review, we don't only look at medications, we look at a thorough medical history. Sometimes you dig back to quite a long way, so it could be years and years, and it's quite time consuming. So what we found here is there are multiple admissions for small bowel obstruction. Pyrazine is contraindicated in people with bowel obstruction. And multiple admissions in October in 2022, mum had just exhausted all options. She's approached the clinicians for options regarding medically assisted death for Dan and referred to palliative care. So Dan, behaviours of concern, screaming, punching in the head, but it's also noted during history that that happens when he's been interrupted from his favourite activity, which is basically, watching TV, or he's been stopped so that he needs to have a shower or change in incontinence pads. So Dan is no longer happy. A few issues to highlight really is the restrictive practice using chemical restraints. So pyrazine's been ongoing for 5 years, and whether there is a place on that. And what we've highlighted also is that there's lack of positive behavioural support input in this instance. So is pyrazine being used as a first line, or has other things been trialed? High doses of opioids and benzodiazepines with quite a lot of changes over time. And again, his risk of death is increased with respiratory depression on background of very low body weight. His BMI is only 12, 13. And although the medications that he's had for end-of-life care is acceptable for someone who's actually been, referred for a proper, life-limiting reasons, there is no clear indication at this stage for Dan that he was actively dying. And also found out that there's a lot of significant change in behaviour after stopping his subcutaneous medications quickly. Then in July, basically what we found out is that his medications been seized by palliative care, and he's mum's described the following week as hell, and Dan was waking up at night, vocalizing, appearing really distressed, and went to a local hospital and has his subcutaneous line reinserted. So when we discussed the medications with mum at time, she's really uncertain about the doses, especially, when you're changing really quickly from one form to another. It gets so confusing for us, let alone for someone who's a carer living in a geographically isolated area. So those support is lacking in this instance. In between then, Dan's had also encounter with our rehab physician, and there was a joint home visit that our clinical care coordinator, our OT, rehab physician and pharmacy visited Dan in early August. And again, because the medications changed, we did another history. We discussed options for, supplementation, because one of the recommendations we did in the initial pharmacy review is to screen for any nutritional deficiencies, given that he's 35 and he's on he's not on much at all. He doesn't have a lot of food either. We also discussed how we could slowly reduce his medicine. Under the direction of our rehab physician, we slowly and gave them a plan of support. We identified the need of PBS in conjunction with using pyrazinamide, but during that course of time, I believe that some of the medicines already been stopped. So this is just to continue to support them. Counseling for carer, which is really important, and continuous support and empowering them and allowing them to know that they can do this and how they would do this and how to identify if the medications are appropriate for them, if it's working or if it's not. So just a quick summary on this case, particularly for pharmacy. We did, a couple of medication history, and some of it could be quite lengthy. We look at it quite thoroughly. We don't just look at medicines, but we look at all the input from our allied health team, which is essential. We investigate the cause of concern of pain and management. In this instance, there are a couple of these medicines that's actually caused about constipation and multiple bowel obstruction. So we've reduced, the antipsychotics. He no longer takes antipsychotics now. And some of his other medications that we thought could contribute to side effects, we've also slowly reduced it. During visits, we talked about bowel management, how we could monitor and recommending part of what we talked about, screening nutritional deficiencies. We trigger a dietitian referral under NDIS funding also, just to ensure that Dan's getting adequate, proper nutritional intake, referral to OT and speech pathologist to optimize environment and to optimize communication. Knowing that he's nonverbal, how can we understand his behavior better? And on top of that, we talked about opioid tapering dose. So we empower mum to reduce the medicine slowly and safely, but regularly following up over the phone or telehealth to ensure that there is no withdrawal side effects. And if there is, what can we do? What can she do during that period of time? So this is a tree. So from what we looked at here, it's a person. So we'll have to understand, as with medications, what medications appropriate for you 2 years ago might not necessarily be appropriate for you right now. So with different seasons in life, we all need possibly different things and different medications to treat certain indications, and what more for someone with intellectual disability who's nonverbal. It's so important to look at it in all perspective, and having looked at it at different points in time to ensure that it's still appropriate and it's still relevant.
Excellent. Okay, I hate to be the last speaker. I think most of the thing I wanted to tell you already know about it, but I'll try to be quick. We probably go a little bit over time, so if you need to leave on time, please feel free to do so. I start with tell you a couple of 4 case vignettes, just to give you an idea of presentation that we see at SAIDHS. Jake, I actually saw him a week before he meant to come to SAIDHS in Lal McEwen Hospital. He's a 21-year-old chap with level 3 autism and multi-moderate ID, non-verbal, generally very settled. A few months before his presentation, his mom noticed just randomly he was curling up and clutching his tummy, he appeared to be in pain. And this time it happened when his carer was taking him to day option. Carer continued to drive and he proceeded to hit the carer. So they stopped. He got out of the car, just got in the middle of the street, cared and hold himself. His carer called his mom, who came and took him to hospital to see if something was wrong. In ED, he got agitated. That one thing led to another. He had a code black. He was sedated, and eventually he was intubated and sent to ICU. Ben, another young 19-year-old man with severe autism and ID. He had been on risperidone, started by a pediatrician a few years back. He gained a lot of weight, mostly wheelchair-bound. He showed significant agitation in the morning when he was being taken to his day option, and in the afternoon when he was coming back home, mainly targeting his mom, who was the main carer. His mom was really at her wit's end, really burnt out and pushing for medication. Charlie, 44, he had lived for a few years in a shared accommodation with support. He had some forensic history for his inappropriate behavior towards minor, and he needed to have constant supervision. He was also involved in a same-sex relationship with another resident at the house, which probably had a higher cognitive function than him, and it was very difficult to establish whether he was able to provide consent or not. He was referred for repeated episodes of agitation. And finally, Aiden. Aiden was 32. He had moderate to severe ID. He had a few month history of increased agitation, restlessness. Just a couple of weeks before his appointment, he was taken to hospital. He was seen and started on new medication. The day that he was brought in, I remember this because this was the week 1 or week 2 I started at SAIDHS, so it was an experience that I don't forget. So his carer brought him in. Carer came in and said, I don't feel safe to take him out of the van. So I went to the car park, and he was literally beside himself, just running at the back of the van, head banging, screaming, and I thought it wasn't safe to let him out. So the carer said he would settle when he was driving, so I asked them to drive him back, and I'll be in touch with you. So these are a few, maybe more severe presentation that are referred to SAIDHS, mostly for challenging behavior, and expectation is to start a medication to fix the problem. I'll come back to these cases at the end. What is the evidence base for use of psychotropic medication for challenging behavior? This is something that Julian talked about as well, so I don't go through much. The fact is that there's very limited evidence to support. Reason are that we have very few RCTs, which are the gold standard research. Adults with ID often excluded from clinical trials because of the other physical health condition. We don't have a standardized measurement tool, so it's very difficult to have a tool to tell you, to measure, for example, aggression or agitation. And we have mixed results. So the summary is based on the evidence that we have available. Use of psychotropics neither can be supported or nor refuted, which is not very helpful, but it tells you that there's certainly room for them. Sometimes it can help, but we have to be careful as well. This is one of the example of a handful of RCTs that we have. It's a comparison between risperidone and haloperidol. Risperidone is the red line, haloperidol is the blue, and placebo is the dotted blue one. Over 12 weeks, targeting aggressive behavior. So as you can see, all three of them reduce the behavior significantly for the first 2 weeks, and then it sort of fluctuates. So there's not much difference between medication and placebo, which tells you whether it's just a placebo effect or whether carer, because they give a medication, then the rating that they do is lower because they feel that they've done something, so it must help. So does this information, this data, actually inform the practice of prescribing psychotropic medication? The answer is no. So depends on which population and which study you look. Something between 32 to 85% of people with ID are prescribed psychotropic for behavioral disturbances. In UK, the primary care data between 1999 and 2013, 49% prescribed, only 21% had psychiatric diagnosis. Off-label prescription is very common, and same again as Julian mentioned, polypharmacy and high doses. Why that's the case? There's pressure from professional and caregivers for immediate resolution of problem. I don't blame them. Sometimes it's really difficult. Often we sit and talk about this, but it's actually the carer who have to face this, or families who have to face this every day. So sometimes it is really difficult and they want a solution. It's a lot easier, cheaper to prescribe a tablet rather than, change environment. We don't have proper training for our carer. Shortfall of psychiatrists. We simply don't have enough psychiatrists, and those that we do, a lot of them don't feel comfortable to see people with ID because we don't have a formal training. And same applies to allied health group. So as a result, that's what we see. So this is one of the cases I saw a couple of years ago. He was on 4 antipsychotic. This is not the only medication that he's on. He was also on a mood stabilizer, benzodiazepine, and antidepressant. But these are just 4 antipsychotic that he was on high doses. If you put all of that together, that's more than 9 times prescribed minimum effective dose for antipsychotic. You never see something, even for someone who has a treatment-resistant schizophrenia in a forensic facility. And this is not a single case. So last time when I presented as RPU, I think the maximum that I had was 7.5. So I'll see if there will be a new record next time. So with help with the previous psychiatrist who started seeing him, and then I continued, we've been able to stop 3 of those and reduce 1 of them. So knowing all of that, what can we do? What helps with our assessment? There is no doubt that assessment is very challenging. I don't go through all of them just for the sake of time, but we all know basic thing that you need for assessment doing a psychiatric assessment or understanding what a behavior means is to be able to know about the subjective experience of the person. And a lot of time we cannot get that with someone who has moderate to severe intellectual or developmental disorder. It is important so the few things that will help us to do a good assessment. We need to have an adequate environment, suitable environment. An ED cubicle in a busy ED ward is never a suitable place to do assessment. Few things that we can do as assessor is, to do our research, to allocate enough time, get as much collateral information. It's very much a detective work. You need to basically get your hand on any information that you can get. School records are very helpful. Explain the process, be flexible with your format, pay attention to patient, that's very important. They may not be able to tell you how they feel, but we all can pick up a difference between a ball thrown as a playful, play gesture or when it's out of anger. So pay attention to the body language and affect during the review, and frequently provide positive feedback. But most importantly, and that's why we're all here as a team, it's a teamwork. You need to have a multidisciplinary, multi-profession, person-centered and integrated team to do a biopsychosocial approach and assessment. This is a list of a few things. Again, I think Julian had the same slide, so I'll go through this. Just the last one on the list, which I spend a few slides on, is the emotional development. This is a relatively new concept that we were not doing it routinely as form of our assessment, and it can give you a really good idea. So same metaphor again, using a jigsaw puzzle, multidisciplinary team, as Steph mentioned, so each of us can look at the problem from different aspects and bring different information, but it also reduces our biases. We all have a different package, different upbringing and different life experiences. So as someone with a neurotypical brain and life experiences, it's very difficult to understand experience of a neurodiverse person. So we are all very prone to be biased and apply our own expectation and understanding to the person. We all can accept a 2-year-old throwing a tantrum. We don't go and prescribe antipsychotic. But when you see a 50-year-old getting agitated, becoming angry because they can't have something that they want, we don't have the same approach, and that's our bias. I'm pretty sure all of you can read this. In fact, if you cannot read what's written here, you have a very unique brain. It's more difficult not to read this. The reason I put it here is nothing is written there. They're just meaningless lines, but our brain is able to fill in the gaps. And that's what I'm talking about, bias. So we fill in those gaps based on experiences that we have and jump into conclusion. One of the key concepts that can help to reduce that bias is the emotional development assessment. It's based on work of Professor Anton Duge, a Croatian-Dutch psychiatrist who sadly passed away 2 years ago. His main idea was cognitive and emotional brain function are located at different regions. So when we do a cognitive assessment, you get an IQ number that does not necessarily tell you the level of emotional development. Emotional development is not just assessing emotion, it also gives you an idea of the sensory motor development, social and cognitive. It has 8 domains, it's listed there, and assess them at different phases of development. This is a summary of an assessment done by my registrar for one of our patients a couple of months ago. So this is a 59-year-old patient, and you can see in different domains. For example, number 1, which is relating to own body, she's past the stage 2, which is the 17 to 18-month-old, and she's navigating 1.5 to 3-year-old. Domain 5, which is relating to peers, she's still at the level of 0 to 6 months. So again, domain 5, you see, so phase 1 is 0 to 6 months. Peers are not recognized, they're seen as objects. So that's understandable why she doesn't get involved in any play, why she's not, interacting with her, with other residents at the house. It's a 200 question questionnaire, 50 for each domain, can be done within 1.5 hours to 2 hours with carer and people who know person very well, and it gives you a very good understanding of the development in each domain. This is, I've presented this before as well, a good sort of model to help you think out of the box. So you have all those assessments, Just to remember, think about other possibilities. The acronym is HELP, so H for health, E environment, L lived experience, and P for psychiatric disorders. Going back to cases that I've told you, so Jake, he's the young guy who was curling up and clutching his tummy. A few months later, during interstate travel, his mom noticed that he does that every time he has pasties or pasta. Turned out that he had a gluten sensitivity, so that was a health issue. Ben, young chap on risperidone, gained a lot of weight, was showing agitation to and from his day option. It turned out that they were using punishment at the day option. One of the previous carer who left let the family know, and it was a police investigation. So it was the environment. When that stopped, his behavior stopped, risperidone stopped, he's lost a lot of weight, a lot healthier. Charlie, when we went through his history, it turned out that he'd been subject to horrible sexual abuse as a child himself. Very horrible stuff. And it is very likely that engaging in the relationship basically brought back those memories. So he moved to a different place. He came off risperidone as well and doing well. So that was the lived experience trauma. And Aidan, again, review of his notes and presentation to hospital was very much suggestive of a bipolar disorder. When he went to hospital, they had started him on antidepressant, which turned him to a manic phase. So after stopping the medication and starting on mood stabilizer, he improved significantly within a week. Normally I would stop here, and I know I'm over time, but just because it's the striking balance, I just want to tell you a few more. Because what I've seen, especially in the last few months maybe, is when reducing restrictive practice can go a little bit too far. So these are the principle of medical ethics, and reducing restrictive practice is very much about giving people autonomy and choice. But we have to be mindful that we have to keep the balance. And sometimes it's very difficult to have balance between duty of care for patient, for people, for others, respect their autonomy, and also avoid causing harm. So these are a few examples. Obviously, there's a lot more to story, but I had a patient who was drinking excessively, sodium dropped to dangerous level. He was at risk of seizure and death, and his fluid restriction wasn't approved. Some guy was running to traffic, damaging other people's car, and carer were not allowed to physically restrict him. So as a result, they stopped taking him out. And also, again, this is relatively common for people who prescribe antipsychotic. They eat, they gain a lot of weight, they get diabetes, but there is no control on their eating habits. There are other areas that we really need to focus. Sometimes if we just focus on one problem, we get a tunnel vision and we lose the periphery. So we need to do a lot of advocacy and better allocation of resources, not just medication. There are people who need better environment. We have a person with severe ID and ASD. His van, he trashed his van and it's waiting for repair for over a year. And that's his only chance to get out of the house. And his behavior obviously increased and they want more medication. So we can solve the problem other ways. In our hospital and inpatient wards, there's a lot of use of restrictive practice. We don't basically have a suitable inpatient ward. It is certainly an area that we need to pay attention, and also same in our prison and justice system. Thank you.
Thank you to all of you who've been able to stay, and I'm conscious that we may have some questions, and I would love to provide an opportunity if you're able to sit tight for a minute or two while we've got the expertise in the room, and I'm particularly keen to do that. I know we're going over time, but I understand we actually haven't got our online people with access to ask questions at the moment. There's been a bit of a tech issue, so you are the brains trust, and I would love for you to be able to at least fire away a couple of questions if you've got any in mind. That broad-ranging presentation and representation of each of the different aspects of a multidisciplinary team. Wonderful. Over to you, Sarah. Thank you.
Test. Yeah. Often these, when the behaviours become extreme, they end up in hospital, which is fairly poorly set up for managing that with care burnout and things like that. Is there an outreach service, or can you provide consultation to complex patients in hospital, or is it something that has to wait until they're in the community? Noting there's the sort of paradox there that often the barrier to them leaving hospital is getting their behaviour to a point that is manageable by the carers, but is not often something that can be achieved in the hospital environment that's not aligns with their normal day-to-day life anyway.
We can, and we have, this is something probably we've had more cases in the last few months, you know, as our clientele and our group goes up, we have people in hospital, and we've done in-reach visit to hospital. Our speech pathologists have been very active in, and I think our nurses as well, yeah. I work in hospital as well 2 days, so I've seen a few patients in Lalmak as well. So certainly, yes, it is something that we do, but the reality is we don't have a suitable ward. So regardless of what you do, if you put a patient with ID in a shared room with 3 other people in a busy, you know, general medical ward, it doesn't end well. Yeah. So that's one of the other things that we're working on as a big research project, to start thinking about what are the pathway and what to create a suitable environment for people with disability when they need to go to hospital. Anything you want?
Yeah, we can accept a referral on that grounds of coming in to do in-reach support. We just try and make it really clear that we don't take over care. So they still need to sit with the home team managing the care, but we're very happy to come in and provide some advice and support.
I don't know if it's a loaded question. So once the assessments have been taken place and you've identified what areas are not appropriate, what sort of trigger points then in regards to additional funding, supports, different pathways, because yeah, like you said, you don't take over supports. What does that sort of look like, the next steps from there?
Yeah, great question. We work with the person's existing community providers. So a significant amount of the work that our allied health team are doing is writing additional supporting evidence for people's NDIS plans. And unfortunately, as Bahman was saying, it's a much cheaper option to prescribe somebody a medication than fund them for a one-on-one ratio of active support during the day to keep them effectively engaged and provide that positive behaviour support effectively. So certainly a big part of our work. I'll be honest, we haven't cracked it. We don't have any major success with guaranteeing that NDIS are going to change somebody's funding either, but we certainly do what we can to provide that additional evidence and try and get some changes happening in their support network and advocate with the escalation pathways that we do have available to us.
I'm just going to yell. I'm a new to South Australia, so I've come across from New South Wales, but one of the things I'm hearing is a lot of work that is being done in the health sector. And I'm also a behaviour specialist and I work in the latest area. What I find lacking is that when someone does present to hospital or is taken to hospital, that quite often the team that's supporting them in that environment are unaware that there's a behaviour practitioner or a positive behaviour practitioner in the community. And a lot of the information that you're seeking we potentially have, and those ABCs and this, you know, any of that kind of data that often doesn't get tapped into, and we get notified post-discharge that medications have changed, and so we're kind of stuck in this area of like, we go back, who are we talking to? That's my own experience. I don't know if anybody else in the same spot or the same field, but yeah, just in terms of how do we go about reaching out to existing teams?
Yeah, great question. I'll take what I can, and then if anyone else wants to chip in, feel free. You are not alone in that experience at all. I will start by reassuring that that's a really consistent experience. There is some statewide work happening that we can't take credit for, but we've consulted with around how we can better manage restrictive practices in our health sector. And part of that is having ways of flagging in our electronic medical record that people have a behaviour support plan, trying to get those plans and information scanned into their medical record. The challenge with that is obviously we need to keep that information current and up to date, and that can change quite frequently for a person. But working out how we can better flag who are the right people to be talking to. There's also a document that we actively promote called My Health Information for when I go to hospital, which is about a 15-page document in easy read format, which really kind of communicates the key pieces of information that a hospital-based team need to know about a person's likes, dislikes, their preferences. If you have to do this, approach it in this way type thing, so that hopefully we can reduce those episodes of codes blacks and things like that for them.
Each hospital has a disability liaison officer. So every time somebody with a disability enters a hospital, it's really good to reach out to them. Yeah, they're invaluable. They'll liaise with yourselves as the external providers, and without anybody contacting the DLO, nobody else is going to take charge of that. So one of the first people, if you know your client's going into hospital, please get in touch with the disability liaison officers through Switchboard. I think every hospital has them.
So two sides to that problem. One, as you mentioned, I've been working with SAIDHS for nearly 3 years now. Before that, I was working and still working psychiatry liaison in Lalmac. I didn't know anything about behavior plans. So it is something that needs for education, and that's what we're trying to do when we have presentation for different hospital and different group to let them know what's the system. But also, as Steph mentioned, one of our basic model of care, one of the recommendation is to develop something as a hospital passport, which is done in many other countries. And whatever you call it, if you can put it in electronic record and Sunrise somehow, so all that information is available. I guess the challenge is you don't want to put too much information there, so you cannot find what you want, but also maybe, I don't know, key people, or just letting someone know that they have a behavioral practitioner and a plan, and then can be accessed when they want to. But it is certainly something that, yeah, we aim to do.
That's fantastic. Look, I'm so sorry, guys. I think we've got time for one more question, then we will have to wrap. For those that do need to head off early, could you please just recycle your lanyards in the box that's been provided on the way out? Also, I will chip in at this point to let you know everything that you've seen today, both earlier this morning and again in this last session, will be available on our website in the coming days, with all the links and all the various things, including hopefully capturing some of these wonderful questions. You can shout. Sure.
Just a question around deprescribing, and when you're providing some expert advice back to GPs and things like that, how receptive do you find that they're following your recommendations? Because we kind of see some resistance around deprescribing, and particularly PRN medication, and not wanting to take that off as an option is causing obviously some challenges for us.
I can say I have probably had more positive experiences, maybe because they're more reassured that we are, if I make a change, I don't discharge patients. If I make a change, I make sure that I remain involved until that happens. Our model of care is not to keep, maintenance because we don't have that resources. So we need to discharge people, but if there is a change, I make sure that I remain involved for some time. So yes, sometimes there are, but that's more exceptions. As long as they know there is support there, I find that GP generally follow what's recommended.
In the absence of a psychiatrist being involved, often GPs are reluctant or unsure about making changes to medication.
I guess from our teams in behaviour support, sometimes that can be challenging to actually ask a GP to rethink their medication regime without having the background and knowledge or experience of the evidence we've seen today.
That's difficult for GP, I guess, if they don't have it. So
Keep advocating, keep trying, it's worthwhile.
Thank you so much, everybody. So appreciate